Hello, everybody. Welcome back to the podcast. We are joined by Nicole Kemble and Michele Barrila-Yetman. Michele, Nicole, thank you so much for making the time.
Thank you for inviting us.
Can you tell us a little bit where you're hailing from and what is your role with the CHNC?
Go ahead.
All right. My name is Michele Barrila-Yetman, and I work at the Children's Hospital of Philadelphia as a clinical data coordinator. And my role is to enter key data fields from the babies that are admitted to our NICU.
I see.
And my name is Nicole Kemble, and I also work at the Children's Hospital of Philadelphia, and I'm a clinical data abstractor, and it's also my role to enter data into the CHND database.
Right.
I want you guys to know, when Anthony wrote us an email about this interview specifically, he said that the data coordinators are the soul and the backbone of the organization. So, in this feels true, right? Your data in predicts your data out. So tell us how you guys ensure kind of this quality control of the data.
Well, what we did 4 years ago now was the data coordinators created a data advisory committee, which broke it down into 5 subcommittees. And my role is part of the data integrity, and within that we look at the MOP, which is the guidebook for data abstractors to find definitions and what does it mean to enter something, and something as simple as
Bacteremia?
Bacteremia. Yes. Oh, thank you.
You're welcome.
So what we do is, okay, does the baby have a blood infection? Yes or no? Or what is clinical sepsis? We have a specific definition around clinical sepsis.
That's why I said bacteremia and not sepsis, because I've been there, yeah.
But actually, clinical sepsis, there's a lot of variability.
Right.
So we have criteria, and in order to enter that in the portal under our infections, the portal we refer to as the database, it's important to know, were there clinical symptoms? Were they treated for 5 days? If those criteria aren't met, we don't enter that.
Right.
So that's how we improve the accuracy and the validity within the database.
And then I'm one of the members, or one of the co-leads of the training and mentoring subcommittee. And so our role is to, we have a lot of new institutions that want to join the CHNC. And we realize the importance of making sure the data that we're inputting is accurate. And so what our role is for the new institutions, we mentor new data coordinators that are at these institutions and kind of guide them through how to put data into our database, how to use their resources, the MOP, the different resources that we've developed over the past 4 years, so that they know how to enter the data, and they are putting in the most valid and correct data for their institution. And we support them, personally, for over a year of time, a one-on-one kind of support. And then we have like a whole group of data coordinators that can support them in a larger way with questions they may have, because we're always learning with the data. Interesting patients come down the line and you don't know what to do. And so you always have a friend, an email away to help you.
I got to tell you, it sounds like an exhausting job. So we're grateful that somebody is able to do it.
Any resentment of the clinicians in our poor way of documenting sometimes?
Oh, yes.
Yes.
If we could go to the bedside and share what is missing, or how we search a medical record just to find an answer. What was the grade of the IVH in a premature baby, so that we can document that? how reflux.
severe is that HIE? Is it mild, moderate, or severe? Please
Right.
tell us.
Right. Because it's not sometimes explicitly
Yeah.
written. Absolutely.
Yes.
Okay, give us more tips. How can we improve our documentation then, especially as it relates to data?
Well, one of the things that we have is our CDH patients, our congenital diaphragmatic hernia patients, are delivered at our institution in our special delivery unit. And our frontline clinicians, our advanced practice providers, our nurse practitioners write an excellent history. And in that, they include specifically, because there is a special module for congenital diaphragmatic hernia, and there are certain things they look for: the LHR, the O to E ratio, is there a fetal MRI? Is the liver up or down? All of those things, to be able to have them in one place when you see the H&P makes it very easy. Otherwise, we are fortunate to be able to have access to the maternal records, and we can go in and look at that MRI, but I'm sure there's other institutions that have to wait to get those records, or it may not be available to them.
Yeah. And I know, our site sponsor is also, an Epic super user, and so we've partnered with him to, talk about like the data elements that we're looking for in the portal, and are there ways to put smart phrases or dot phrases or whatever in Epic that it can pull that information that we need easily into a note. So that there's one place to find it. And I would say, like, when we come across a stellar note from a staff member, like a transport note, particularly with HIE, where we're documenting temperatures and cooling and the time they left and arrived at the institution. When we find a note that's really wonderful documentation, we often send a thank you and really encouraging them.
I like
A
that.
documentation award.
Yeah, really encouraging them and thanking them for that note, and we hope that positive reinforcement
That's true.
translates into a wider array of stellar documentation.
But I think this is a really important point. You guys, as a group, are trying to standardize documentation so that the data is much cleaner.
Yes.
Very interesting.
So I mentioned that we created 5 subcommittees. One of them is data coordinators on the focus groups, and there are 27 focus groups for the CHNC, and each of those focus groups has a data coordinator.
I see.
And their role is to facilitate those members of the focus group when they have a question about the database, what data fields are available. And every focus group wants to have more data fields added, and they have to get into the queue, but we explain what is the definition, and some things have changed and really improved. So an example would be acute kidney injury, and the criteria from the renal group for, while we may see it in the medical record as a diagnosis, according to our definition, it has to meet certain criteria in order for us to enter it. And that came out of the focus group.
Yeah.
I was going to ask you about that because I've worked with databases and data in the past, and I think to me that's the most terrifying aspect of it, is that you initially set a set of values, you initially set a data, and you say, okay, these are my definitions, but then if you keep the database alive long enough, definitions change, and then the question becomes, are we going to go back and reassess now how all these babies now are faring in terms of this new definition? How do you deal with that, especially, as you said, you mentioned the change in the kidney injury definitions, but there are many things that are changing over time. Now, BPD is one of them. I think it's going back and forth, but how do you deal with that?
So the CHND has a manager who keeps track of when we've made changes to the database, when certain things have been instituted, so that they can look back retrospectively. If a researcher wishes to have a data pull, they can say, from this point on, we had a different definition.
I see. So it's almost like the neurodevelopmental outcomes when the Bailey gets updated. It's like you cannot retest these kids. You just say, oh, these were the times where they were tested on the Bailey 2 and now they're tested on the Bailey 3. That makes sense.
Yes.
Yeah, and I mean, medicine is always, neonatology is always progressing, learning. There's so much new information, new ways of doing things, and so the database is similar in that it's a living thing and it continues to progress with the times of medicine.
But there's always this want of like, I could potentially get more patients.
So many more babies.
Right? That's like, ooh, what if I went and did look back at these 100 charts? Maybe I could get like 100 more babies for my study. So I think you always have to balance the sheer amount of work that it would require versus like, ooh, another extra few babies for my study.
So when you talk about the database, we also have a database application subcommittee, and they do a lot of the testing of new platforms when we have new modules in our database, and how is it working, how easy is it, and that is also where the data coordinators play a significant part in what is the lift in trying to find that. And that was how we originally arrived at the acute kidney injury definition, because how and what are you asking of the data coordinators to look through all of the serum creatinines and make a decision? That can be a bit challenging and daunting, and how much time and value is in that.
Yeah, and we, the fetal focus group mentioned like they would love to have a fetal surgery module, and it's like, yes, that would be wonderful, but you also have to keep in mind, well, what data is available to people? Like, are you at an institution where you have a special delivery unit and you can easily gather if a patient had any fetal therapy, fetal surgery, or are you a strictly referral hospital where you get the patients after they've been delivered? And what kind of access, what's the lift for you to find that information? And so I think, as data coordinators, we enjoy abstracting data, and enjoy, looking through charts, but then you also have to think, well, how available is that information for the whole group of institutions? And, what would be your source of truth to find that? And so there's a fine line between wanting more data, but, what is the bandwidth available for that kind of thing?
Well, I really love this conversation because I have this, physicians, I'll say, in general, feel like we can do everything, right? We can do all the parts of all the things. We have all this expertise. But this is a really skilled work to do the data collection and coordination. So what sort of training goes in for your data coordinators?
I'm going to let Nicole take that because that's her specialty subcommittee.
Okay, yeah, so on the training and mentoring subcommittee, I would say when 5 years ago, before our subcommittees, there really wasn't a whole lot of training materials available. And so over the past 4 years, we've kind of developed a lot of onboarding kind of documents to help people. So documents that show them the resources that the data integrity group has provided. Our main resources always are manual. We have our appendix resource guide. We show people how to use that document, because a lot of times staff that take on these roles are coming from a clinical area and may not know how to use Excel, and so we show them how to search the whole workbook. We've come up with we call it a recipe for success. Like, when I'm abstracting, these are the things I need. These are the steps I need to take. And we are volunteers, and we can't sit with somebody individually and help them abstract all the time, but we also in the past year have done a training and mentoring office hours where we've been taking different modules and going through the modules, answering the questions with our MOP, fielding questions from people, and then we have it recorded so that anybody can refer back to an office hours, and if they need help with the neuro module, they can watch a video that can guide them through.
My last question for you both, and maybe you can speak on behalf of your entire group, is do you appreciate, as the CHNC is able to churn out papers and data, set standards, and ultimately improve the lives of many newborn babies, do you guys grasp the impact you've had in making this happen? Because I think that as we get away from the bedside, we can feel like maybe we don't matter as much, but I mean, as a clinician, the work you're doing is critical, especially when we're looking at, like Daphna was mentioning, the integrity of the data and so on. So is that something that is very present as in your group, this feeling?
I think across the board we realize what the value is. And I will share, a couple of weeks ago, we had an opportunity to help out our psychologist in a parent group for promotional material, but we had the opportunity to sit with a mother who shared her story and her child's journey in our NICU, and it was really nice. And Nicole and I were both there, and we thanked her because we were able to put a face and a story to the data that we are entering.
Right.
And that makes it very meaningful when we know we're searching for 20 minutes looking for that one piece of information, and to know that the care and watching the papers, and when they say we pulled this information from the database, this is from the database, we get very excited about that, and we know the quality of what we are providing.
That's awesome.
And I know that, since, I started with the CHNC, I've always appreciated the emphasis that Dr. Evans and really the whole group has put on the importance of the data coordinators and really valuing the work that we do. And that just really, I think, encourages most of us. We all want to do an excellent job. We want excellent high-quality data. And when we see the data being used by different focus groups and papers, that just makes us feel so much more valued for the work that we're doing. And that's just something I've really appreciated, that they really value our efforts to make a high-quality database.
Well, to your point, I feel like you guys are the closest you're the closest to the data, right? And so I wonder, especially for, people at different institutions who, can only see a handful of babies, but you guys are seeing the collective data coming in. Is it ever the data coordinators who say, like, maybe there's a question here, there's an interesting trend that I have noticed in the data?
We do, because Nicole and I, and we have one other coworker, and the three of us, we work together in what we call Abstractors Alley at our home institution. And when we are in person in the office, we can sit there and say, oh my goodness, have you seen this? We're seeing...
So cool.
So we joke and say, we're having a special on CDHs
this week,
or we were having a trend in HIEs or whatever it might be, but we don't necessarily pull that to the clinicians, but we comment to each other, oh, we're seeing this, have you noticed this? And the other part is, because we're in the charts oftentimes after the babies have been discharged. So we don't necessarily have anything now we will, in real time. We have worked very hard, and our real time is 200 open charts, episodes of care. So we probably will be able to have more opportunities to do that in the future.
Very exciting.
Yeah, and we know we have some physicians that, have a question about, how many patients are we sending home on like NG feeds, for example. And we're, able to pull that data from the database, but then since they've already asked for it, it keeps it top of mind so that we can kind of see, they're trying to discharge patients sooner. We're seeing more patients going home on NG feeds with like good telehealth follow-up. That keeps us, mindful of certain trends that are coming through the NICU.
Telemedicine has been a big one.
A big one.
We've really tried to capture that in one of the fields of discharge follow-up appointments. So we have a free text group. So that other box, whenever you create surveys and it's that write-in field, we really tried to create a level of consistency, and we have a group that follows and monitors what free text is being entered, and if they're seeing a large part of that they then generate either a new diagnosis, a new field based upon that.
Interesting.
Because free text is difficult.
Sure.
It's
too abstract.
And so we try and minimize. That's why we have that free text group. Minimize free texting. Is there someplace else to put it? That way the data remains valuable, and it's not a field that doesn't really tell you the story because everybody's entered something different.
Yeah. Very interesting. Thank you both for the work that you do. We know it's changing what we do at the bedside. So, Michele, Nicole, thank you for your time.
Thank you so
very
much for having us.
We enjoyed it.
Thank you, guys.